Generally, as per my experience, rarely we have given any red alert in March in maybe in past so many years. So this year we have given, considering minimum temperatures also. Another factor, humidity. It is not so high, but it's still, I mean, humidity is normal or slightly above normal over the Saurashtra and Kutch area. Considering all these factors, we have given red alerts for Gujarat and entire Gujarat. And after 24 hours, we are expecting a western disturbance is likely to affect northwest India. So there will be a slightly fall in temperatures. What heat wave to severe heat wave may continue over Gujarat next 2 days, and thereafter it will await, because we are expecting rainfall activity over the most part of northwest India, and there will be a slightly winds coming from northwest India or northern part of Pakistan. That will be the cooler wind and reduce the temperatures, and there will be, we can say, uh, slightly, and there will be a weather activity over entire northwest India, starting from Himalaya region, and we may experience heavy snow, heavy rainfall over Himalaya region also on 14. So this is about, and this is again district wise. I have just given the examples. District wise forecast issued by our subdivisions, sorry, states, that is MC Ahmedabad, that they have issued. Sorry, another things, we are also expecting heat wave over West Rajasthan, specifically Southwest Rajasthan. So here also we have given directly orange color instead of yellow. Again, reason is there are only two stations that we are experiencing heat wave, but again minimum temperature is also higher side. So we have given here orange alert for next 2 days, and thereafter we are expecting from day 3, 13, 14th, heat wave may occur over the central part of Maharashtra, specifically Vidarbha regions. Then we may also experience heat wave over Odisha, starting from 13, 14, 15 for the 14 to that is 15 for 3 days. So this is about heat wave temperature, sorry, heat wave forecast and for the country for next 4 5 days. So this is our district wise heat wave warnings. So we have many districts in Saurashtra Kutch also, it is covered with red, and day 2 the warning is reduced to the orange. Yeah, thank you very much. That's all.
Thank you very much, Dr. Naresh. Is there any question for Dr. Naresh from participants? I don't see any questions. Okay. Thank you very much, sir, for the overview of the forecast and all the early warnings that are provided. Thank you. So we will move on to our next speaker. We will have Dr. Ajay Chauhan. He is a Director, Professor of Medicine in RML Hospital, and he has been associated with NPCCH since the beginning and has been a member of expert committees on heat and health, which have drafted National Action Plan on heat-related illnesses and emergency cooling in severe HRI. Last year, he took initiative in establishing heat stroke management unit in RML Hospital, which has helped save many lives and reduce mortality in heat stroke patients during heat wave of Delhi. And hopefully we will listen from him about that with his topic on clinical management of HRI in adults. So I will hand it over to Dr. Ajay now. So you can unmute.
Yeah. You have just now unmuted me.
Yeah.
Okay. And can I share my screen with others?
Yes.
Kindly
Yes.
allow that option.
I think you can share.
Yeah.
Those.
Is
Yeah.
my voice audible to one and all?
You are audible, sir.
And is
Yes.
my
Now
screen
screen
visible?
visible. Yes, visible, sir.
Thank you. Warmest of greeting from RML Hospital. Although I wonder how appropriate is it to greet warm wishes in a heat stroke, heat-related illnesses seminar. But nonetheless, you are joined from various parts of India, and I am hopeful that I'll be able to impart some kind of knowledge and increase your knowledge in managing heat-related illnesses cases. Uh, this is a seminar of half an hour, so it is pretty much a very short time in order for me to complete all. So I will be scampering through some of my slides, although where emphasis is needed, I will make sure that I emphasize on those slides. So heat-related illnesses are a part of climate change, and it is manifesting all across the world in various forms like cyclone, tropical storms, and extreme rainy events. And no matter what we do, this seems to be going ahead with utmost ferocity. Every passing year we read this, that this is the warmest year. So as clinician, it is imperative for all of us to learn about the management, because that is only what we can do. So temperatures have been covered by the scientists from IMD. So before discussing, I would like to briefly overview what is the magnitude of the problem. So heat-related deaths are there in all across the world. US reports approximately 255 per year as per CDC, 302, and as per US EPA, 255. So if we consider CDC value as a true figure, the US have about 702 deaths a year, and Europe about 8,000. Perhaps their data capturing is much more robust, besides the fact that Europe is about 3 times the size of population of America. In India, however, all these years, reporting was quite low. So we had between 2015 to 19 at an average of 755 cases of heat stroke. But then we buckled up. We created a lot of sensitization workshop also, as a result of which now the reporting is very robust. And the latest is, what is important is, this year in 2024, we had about 45,000 cases of heat stroke reported. And mortality data, Dr. Purvi can explain it much better. From where I sit in RML hospital, I have been working for the past 15 years now. Never had we have so many cases, let alone, this magnitude was immense. This year we had 75 heat stroke cases, and we had unfortunately 27 people dying despite our best measure. And ours is a tertiary care center with a blood bank, component bank, ventilator, and youth, whatnot. Still, so the problem does carry a very high mortality. So we should, in all our earnest, try to learn what can be done to prevent it and manage it. So temperature, I'll just go through quickly, then I will give you a brief overview of human adaptation to heat, and then spectrum of heat-related illness, which can be as innocuous from like a prickly heat, colloquially called ghamori in Hindi, to as serious and deadly a disease as heat stroke. And I will be focusing more on heat stroke and cooling strategies because of the paucity of time. So heat is not, this already has been covered when it is called heat wave. So heat is not only a temperature, it is a composite endpoint of 4 factors on human health. Insofar as human health is concerned, we have to consider not only the temperature, but 4 factors in fact. These are temperature, radiant heat, air velocity, and humidity. So as you would see in this slide, unfortunately, the temperature, I picked it up from a Western, so the temperature is all in Fahrenheit, but I converted it. Look at the x-axis on the top, 90 degrees. 90 degrees Fahrenheit is about 32 degrees Celsius. So uh, at 32 degrees Celsius, 32 would come across to you as a okay weather. Okay, 32 is not such a severe heat wave. But if there is, and then you extrapolate it on y-axis, at 90 degree of relative humidity, this 90 becomes 122, which is 50 degrees centigrade. So 32 at 90 degree of humidity becomes 50 degrees centigrade for human perception and human health. So we always should factor in not only the heat, but relative humidity, air velocity, and radiant heat also. And this is the temperature measure, wet bulb globe temperature, which measures all four and gives us a composite value, which is much more apt insofar as effects on human health are concerned. So this is what we get on Google. If you search Goa weather now, so it will be feels like is 32. Actually, it is 28. So how does human beings adapt to this intense heat? In fact, all heat related illnesses, more so heat stroke and heat exhaustion, are a disturbance between input and output mechanism. Basically, the body is unable to dissipate the heat which it is generating either because of hard work, namely exercise, which increases it to as many as 20-fold, fever, shivering, tremors, convulsions, thyrotoxicosis, sepsis, and some drugs, or is it because of ambient temperatures? If the input is more and the output is less, we suffer from the consequences of heat-related illnesses. And the method of heat losses are, as we have all read in our physics classes in our childhood, convection, conduction, evaporation, and radiation. Now, the most important mechanism in a normal state of affairs, in our normal state day-to-day life, are convection and evaporation. But at a higher relative humidity, more than 70%, this evaporation, which is sweating mechanism of heat loss, somehow gets blunted. And so, there is one mechanism, conduction, which is a very which contributes a very minuscule amount in normal day-to-day life. But when it comes to cooling strategies, this becomes the most important because it is a very fast rate of cooling of human body, this conduction method. And we will delve upon this later in our session. So when we ask people to wear light color clothes and porous cotton clothes in summers, that is what we are referring to. We want to increase their convection because of porous clothes, and light color clothes increase the radiant transfer of heat. And the master of all this phenomena in our body is hypothalamus, which matches the temperature outside to the core body temperature and takes appropriate decisions like increased perspiration, vasodilation. But this is not common in all human beings. This is not equal amongst all. Why is it so? Because as you can see, this is a coronal section of human body. So there's a core in which we measure temperature. Then there is a muscle which varies from people to people. Then there is a subcutaneous fat. Then there is a vascular skin, avascular skin. Then there is a clothing layer. And as you might observe that there are, for all these things, a person can be more muscular, less muscular, more fatty, less fatty. So heat-related illnesses and heat exhaustion, heat stroke are a composite endpoint of based on human to human. And some people develop this robust physiologic acclimatization to heat-related illnesses. And how does it happen? It happens by increased rate of sweating. Normal human beings sweat as much as half liter to 1 liter. But in trained athletes, they can go as high as even 4 to 5 liters per hour, which is mind-boggling rate if you see. And plasma volume expansion also occurs. The cutaneous vascular flow goes as much as 20 to 30 times the normal flow. So our body is a pretty effective machine if we see it that way. decreased Planck, the central blood flow decreases, heart rate lowers with a higher stroke volume. There is a adaptation at a molecular level also in form of heat-related cytokines, which increase our adaptation. But the most important thing for us clinicians to remember in this slide is one, which is it takes several weeks for acclimatization to happen, but de-acclimatization takes place only in a few weeks. So in heat stroke, you will have a history that I am an army jawan, army soldier. I run for so many kilometers with a pittu on my back and nothing will happen to me. This jawan goes to chutti and then comes back and assumes the same degree of effort, then he goes into a state of heat stroke. So a rickshaw puller goes from Delhi to his native place. He's an immigrant rickshaw puller. His body is acclimatized. Now he rests in his hometown, comes back, resumes the same level of physical activity, suffers from a heat stroke. That is a very common factor which you have to take into account in history taking. So the climatization takes place during a period of several weeks, whereas de-acclimatization takes place very, very quickly. And then I am taking a segue. This is because the teacher in me can't stop. There is a difference between fever and hyperthermia. This, as a consequence of heat stroke is a condition of hyperthermia. In fever, hypothalamus is wanting the body temperature to rise because by releasing interleukins as a method to combat infection. And there is another term, hyperpyrexia. In pre-antibiotics the first antibiotic came across 150, 200 years back. Before that, there were no antibiotics. So the only mechanism by which body coped with infection was raising temperature. But this cannot go on in perpetuity. There is a limit to which body can raise temperature, this limit is called as hyperpyrexia, which is 106.7. Cannot go beyond that. So this is hyperpyrexia is a variant of fever. And hyperthermia, body doesn't want temperature to increase. Hypothalamus is in fact doing all physiological adaptations to decrease the core body temperature. But the mechanism have failed or have been overwhelmed. That is the reason the core body temperature can rise. And that is the reason we don't use paracetamols. What does paracetamol do? Paracetamol decrease pyrogens in our body, thereby decreasing fever. But in hyperthermia, namely heat stroke and heat exhaustion, there are no pyrogens. So paracetamol won't work. In fact, it will cause damage. The only thing which works definitely is cooling. So there are some risk factors, namely extreme of ages, people taking beta blockers, calcium channel blockers, diuretics, SSRIs. These you see are very, very common drugs, very common. Hypertension, beta blockers, ECBs, these are very common drugs. Then substance of abuse, cocaine, amphetamines, ethanol, namely alcohol. So all these are more vulnerable to the side effects of heat-related illness. At risk are also laborers, military personnel, or athletes because of their poor conditioning and lack of acclimatization. Occlusive clothing is also a very important factor. So heat-related illnesses are a spectrum which range from an innocuous condition such as prickly heat to increasing degree of severity, namely heat syncope, hyperventilation tetany, heat edema, heat cramps, and then there are two big, most dreaded condition, heat exhaustion and then heat stroke with highly lethal conditions. So let's see them one by one. Prickly heat, scientifically called as miliaria rubra lycanthropicus or ghamori in Hindi, is a maculopapular pruritic rash secondary to the blockade of sweat posed by the debris from macerated skin. And the predominant symptom is pruritus. Usually it happens in children with poor hygiene, wearing tight clothes, non-cotton clothes, and treatment is very simple. We give antihistaminics, chlorhexidine cream can also be used. We can advise people to move away from heat and wear breathable clothing and loose fitting clothing. Then we have a condition called as heat edema, and it is secondary to the cutaneous vasodilation as a compensatory mechanism against heat. Also, there is a slight increase in ADH, and it results in mild swelling of heat in hands and feet. And usually it occurs in early summers, and it resolves in 4 to 5 days. Nothing much is required. You should not endeavor to give a person as diuretics, not really useful. In fact, they can cause volume depletion. Then we also have a condition called as hyperventilation tetany, because in order to lose heat quickly, uh, some people hyperventilate in heat in this condition, and already their calcium is on the borderline, so they can develop a precipitous decline in serum calcium level, thereby leading to a carpopedal spasm. Not much is required except for moving away from heat and reassuring them so that they don't hyperventilate. In worst case scenario, we can give calcium also. Then we have something called as heat-associated cramps. Very commonly, you must have seen unacclimated individual doing vigorous exercise and replacing fluid loss with copious water rather than putting electrolytes in. So these are intermittent, painful, involuntary contraction of skeletal muscles, and usually self-corrected by resting in a cool environment. If the need be, oral or IV electrolytes may be used. Half a teaspoon of salt in 1 liter of water, and these pass off quickly. Then in some cases, you will see, especially in school children during assembly, you will have cases in which there is a loss of consciousness. कि भाई धूप में खड़े हुए थे और अचानक से गिर पड़े. So this is because of two mechanisms. The pathophysiology is such that prolonged exposure of heat causes cutaneous vasodilatation. All of a sudden, there is a change in posture. Then there is a postural drop, and people fall down because of heat syncope. The treatment is very simple. You have to put a person in shade, raise his or her leg, and rehydrate him or her. Then we come to the relatively much more severe condition. This is heat exhaustion and heat stroke. First, we will discuss about heat exhaustion. Heat exhaustion basically are of two types: water depletion and salt depletion. Water depletion occurs in people who are somewhat acclimated to heat. So they are laborers, athletes. Somehow it is shown that their thirst reflex is blunted. So if a factory worker in damp environment, in a very hot and humid environment is working for long hours, if he has done this work for months and years together, somehow the thirst reflex gets blunted. So this kind of people will present to us with both water as well as electrolyte depletion. However, in cases of unacclimated person who have just been exposed to it once or twice or thrice in their lifetime, they cope up with the heat by consuming large amount of water or things which are hypotonic, doesn't contain adequate amount of sodium. So they develop salt depletion variant of the heat exhaustion. And the sign and symptoms are milder than heat stroke: headache, vertigo, ataxia, impaired judgment. And we can also have some interesting gastrointestinal symptoms. So whenever there is a heat exhaustion, we all think there will be neurologic symptom, but we should always pay heed to gastrointestinal symptoms also, like nausea. People may have loose motions also. Previous is hypotension. People can have tachycardia. When we do lab investigation in these cases, we get very unexpected lines: low sodium, high PCV, and in some cases, the SGOT-PT can be slightly raised. If we do their urea, sodium, and chloride, they are less as a uh, compensatory mechanism by the kidney to preserve the electrolytes. Treatment is simple. We have to remove the patient from a heat stress area and aggressively cool him or her until the core temperature. And this is that thing which I keep on repeating again and again. All heat related emergencies, the only temperature which is of value and which should guide our clinical decisions is core temperature, which is the rectal temperature. So we cool him or her up to 100, between 100 and 102 loosely put. And we infuse him or her with rapid IV fluids and guided by his electrolyte determination. And one thing is very important: we should not try to correct the serum osmolarity too quickly, it may be disastrous for a person. So we should go slow about it, no more than 2 milliosmoles per hour. And lastly, I've written the serum osmolarity. I've Indianized the formula given in Harrison: 2 times sodium plus plasma glucose divided by 18 plus urea divided by 6. Because in Western books, it is 1 divided by 2.3. So this is urea divided by 6. Then heat stroke and heat exhaustion have a lot of overlapping features. But the basic pathophysiological difference is that in heat exhaustion, some kind of thermoregulation is still maintained. But in heat stroke, which is the most lethal of all, there is a total and absolute loss of thermoregulations. And besides, in heat strokes, you will more often than not, we get loss of consciousness. Heat exhaustion, we may get loss of consciousness, and in heat stroke, we may not lose consciousness also. Both opposite can happen also. But in overwhelming number of cases, heat stroke is loss of consciousness, and heat exhaustion is very, very tired, ataxic, faint, dizzy, that kind of person. So now we come to the most dreaded of all complication of heat-related illnesses, which is heat stroke. And it is a triad. 3 conditions are required to be met in order for us to declare a person of having suffering from heat stroke. These are exposure to heat stress. Now, this is a relative term. So we have to factor in all the things: heat, surroundings, airflow in and around that person, a factory worker with no cooler, no water to drink, factory covered by all sides, no windows. Even at 38 degree, we will mark it as heat state. There is no fixed temperature. You have to use your clinical judgment. Then 2 symptoms are easy. CNS dysfunction has to be there, and the core body temperature has to be more than 105 degree Fahrenheit or 40.5 degree centigrade. If these 3 criteria are met, then we label the person as having heat stroke. And now these are of 2 variants, classic and exertional. Exertional are more commonly seen in laborers, military personnel, more in exercise setting. In this, we have a kidney injury is immense, rhabdomyolysis is a lot. So we'll have very, very high values of CPK. And electrolyte disturbances will be more robust. Whereas in classic heat stroke are seen in elderly, children, people on medicine, having sedentary lifestyle. So these kind of people will have a relatively lesser CPK rise and electrolyte imbalances. And the poor prognosis markers are if an initial temperature is more than 106, and if the temperature persists to 102 degree Fahrenheit despite aggressive cooling measures, coma duration longer than 2 hours, pulmonary edema, delayed or prolonged hypotension, lactic acidosis, SGOT-PT more than 1000, acute kidney injury, and moreover, pre-existing disease such as diabetes, bedridden. These are harbinger of adverse prognosis in patients. And delayed therapy, the mortality rate is up to 80%. Early cooling, mortality rate drops down to 10%. So that is the reason we emphasize so much on early cooling, field cooling measures. And general physical examination in heat stroke is people will have tachycardia with wide pulse pressure. Hypotension can also be seen, but before most important factor is to cool them down. This will help in settling hypotension, obviously, besides giving him or her fluids. So in CNS, we can have irritability, delirium, confusion. Usually, more often than not, they'll be confused. Idhar udhar ka bol rahe honge. They'll be agitated. We had 75 cases this year. All were absolutely. Some people came very low in even V1, F1. Overwhelming number was irritable, difficult to manage, aggressive. Then we can have ataxia, tremors, dysarthria, and very sick cases may have decorticate or decerebrate posturing also. We can have cranial nerve abnormalities, and important to notice pupils can be normal, dilated, and pinpoint. All 3 variants can be seen. So this is very important when it comes to differentiating it from a pontine stroke. Then in CVS, we usually have tachycardia, and A hypodynamic state can also be seen secondary to volume loss. And CVP should be our guiding principle in order for fluid resuscitation. We can also have damage to other system, namely gastrointestinal hemorrhage, liver. There can be a jaundice because of traumatic damage secondary to heat for liver enzyme. We can have a patient with DIC, musculoskeletal like rhabdomyolysis, kidney injuries. This can all be seen. We can also have lung collapse and pulmonary infarction. Differential diagnosis is very important. Differential hepatic encephalopathy, hyperthyroidism, hyponatremia, delirium tremens, snake bite, tetanus. These are not so uncommon. So basically, all the diagnosis of heat stroke is clinical. But investigations we do to rule out things. Suppose we have something in our mind that this can be a case of this or that, then investigations are basically meant to rule out some other conditions. So lab investigation, as expected, there will be leukocytosis, high PCV, decreased platelet count. Then we can have microscopic hematuria, myoglobinuria in urine analysis. SGOT-PT may go up as much as 100 times. We can have disturbed coagulation study. And we can have metabolic acidosis in the ABG, lactate levels being raised. ECG may show a variety of usually tachyarrhythmias. Brady's are less commonly seen with non-specific STD changes secondary to heat-related infarct. Chest X-ray may show lung collapse, pneumonia, or ARDS. Then CT scan is basically to rule out stroke and other causes. It has, in heat stroke, it doesn't have much of a role in positively affirming a diagnosis. It is done to rule out other things. And before shifting a patient to hospital, we must immediately remove the patient from the heat environment, and cooling should be initiated as quickly as we can. Ideally, we should remove clothing, but we should not wait to remove all the clothing. The early cooling is mandatory. If we have access to immersion cooling, we should not be waiting too much. And patient should be transported by air-conditioned vehicle if possible. Now, there are some golden rules in managing these cases, which are the cooling must begin immediately and must be continued during even the patient resuscitation. And second is very, very important. Most of the people try to treat heat stroke by rehydration therapy. They think we'll give fluids, patient will become all right. This is the biggest myth, very high mortality rate. Rehydration therapy, albeit important, but alone it is insufficient for the heat stroke patient. Surface or oral temperature doesn't accurately reflect core body temperature, and the rectal is preferred method. Being fast in starting cooling saves life. Antipyretics, as I have discussed in details, have no role. And in emergency situation, the distinction between exertional and classical heat stroke is less relevant. I'll delve upon this point a bit Then we have to take breaks after some time in order to prevent heat stroke. Then we come to, besides initial resuscitation, we have to treat complications, which can be hypotension, cardiovascular, renal failure, as we do, seizures, coagulopathy. We always start by giving a person high supplemental oxygen. Fluid choice depends on the presence of hypovolemia and metabolic and other comorbidities. And important to note is cooling alone may improve hypotension and cardiac function. So cooling definitely has the biggest role. And aggressive fluid resuscitation is generally not recommended. Must be guided by CVP and pulmonary wedge pressure monitoring. Hypoglycemia is a very, very frequent finding and simply can be addressed by glucose infusion. And dobutamine is the inotrope of choice. If at all we require to use, it is wise not to use alpha agonist, because they will call vasoconstriction, thereby stopping the heat loss quickly. We can have coagulopathies and hepatic injuries, and in which case we use fresh frozen plasma if person is bleeding, and no role of styptics like epsilon aminocaproic acid, increase rhabdomer. And one more important thing, seizures. Person presenting to us with seizures should ideally be treated by short-acting benzodiazepine. Usually what we do in our setting is we injection Levira or injection valproate infusion or Aptoin. All three are not really recommended. Barbiturate prevent heat loss, so are not useful. Valproate damage liver, and phenytoin is not effective. So best in seizures of heat stroke is short-acting VZD's infusion. Lorazepam or midazolam we can use as infusion. Then respiratory complications have to be treated, and so does dyselectroitemia. Cardiovascular complications also happen very frequently, and we have to be managed with aggressive cooling and fluid therapy. Tachyarrhythmias, we don't require to use cordarone or diltiazem much because they resolve spontaneously by cooling. Rhabdomyolysis, we treat it by large amount of intravenous fluid and if required alkalinization of urine, infusion of mannitol, and in worst case we have to resort to even hemodialysis. So now we come to very important, how do we cool the person? There are two kinds of cooling, evaporative and immersive cooling. Evaporative, although is very practical, in which we spread cool water and fan the person. Cold packs can also be applied to neck, axilla, and it can be used in classical or non-exertional heat stroke. But the rate of cooling through evaporate cooling is only 1/5 of required rate of cooling. Required rate of cooling is 0.15 degrees centigrade per minute, whereas this can maximum achieve 0.03. So it is 1/5 what is required in case of exertional heat stroke. In CHS, it can be used. So now we come to immersion cooling. It's the best method of cooling because the conductivity of water is about 25 times that of air. It's a preferred option in EHS, but it can induce peripheral vasoconstriction shivering. But research after research has shown that the benefits of this method outweighs its risk. So the technique does present significant amount of monitoring and resuscitation challenges, and it is the best for young and previously healthy patient with exertional heat stroke. And to the very important point, to avoid hypothermic after drop, cooling should be stopped at 101, 102. We should not endeavor to, cool him up to 98.6. We should stop cooling at 101. Then there is an after drop. Once you bring the person out of the cooling tub. And then we have fancy blankets, cooling blankets, no role. IV infusion of cold fluid we can give. Peritoneal lavage, thoracic lavage, effective, but even we can go for pulmonary bypass. We have such machine, but it does provide effective cooling, but it is very rare, and I don't think it is relevant. The most relevant is immersion cooling, as I will show you. So the take-home message for this is early confirmation and cool first is the strategy to be followed, and we should be very quick in rapidly instituting the cooling measure. And morbidity and mortality directly related to the duration of core temperature. Every minute counts. So these are various field methods I have incorporated, which can be used for aggressive early cooling of patient. This is something called as TACO, टार्पोलिन असिस्टेड कूलिंग ऑसिलेशन. टार्पोलिन को हिंदी में त्रिपाल भी कहते हैं. तो ये देखिए आप लोग.
What would you do if you were out on the trail and saw a runner who was suddenly overcome by the heat?
Severe hypothermia dangers include seizures, brain damage, and even potentially death. Are you okay?
Heat stroke can happen while running, camping, or at any outdoor event. Luckily, a tarp and water is all you need to cool them down.
Right, let's roll her. We need to get her in this tarp.
Chris Sampson, an emergency medicine physician at University of Missouri Healthcare, helps us demonstrate the TACO method.
Now we need to put some ice on her and get water on her as well, and pick up the tarp.
TACO stands for Tarp-Assisted Cooling with Oscillation.
The TACO method is very important for people who you may encounter that are confused, unresponsive, or have passed out from the heat and will not wake up. These people often need rapid cooling in order to help save their lives.
If someone is unresponsive, get them onto a tarp. Pour water and ice on top of them. Then keep the tarp moving.
Most of your heat dissipation occurs on the surface of your skin, and by oscillating or moving the tarp back and forth and having that cold water get in contact with all portions of their body, you're able to get the heat off them in a more.
So we saw in this, they put a patient in tarpaulin and they put some ice cubes, put some water and started oscillating a person. Similarly, body bags have also been used. They are impervious material, made up of impervious material. People are chained up to this body bag is chained up to the person's neck, and then they put ice. So a lot of methods are used, and it is not all because we have tried to incorporate these methods. We have established a state-of-the-art heat stroke room here in RML Hospital. It has, and this is the picture which I am sharing with you. It has 2 immersion tubs of capacity 250 liters. On the left side, I think on the left side of the picture is our ice making machine. And if you mix about 150 liters of water and 70 kgs of ice, quickly the temperature drops down to 0 to 5 degrees centigrade of water. So this is the recommended, and we immerse the person in this tub. We also have tarpaulin, we also have inflatable tubs, we also have ice boxes in our ambulances. During the course of summer we keep them, and this is our own patient which we have instituted this cooling. Unfortunately there's no video, but you have to keep on oscillating the water. This is a short video.
रेक्टल प्रोब दिखाओ जरा, टर्न करो, ये एजुकेशनल पर्पस के लिए टर्न हिम, प्लीज टर्न हिम, आई वांट टू शूट दैट. ये 15 सेंटीमीटर्स इनसाइड है ना, ठीक है, चलो डालो ऐसे. इसमें कितना आ रहा है?
इसमें तो 102.9 ऑन पेपर्स इट वाज 100.
This is rectal and is going up. See, it is going up. You ये डालो ऐसे, wait मत करो. Every minute counts. डालो. Brother,
प्रोब डालो.
ये क्या, ये कहाँ से है? हमारे यहाँ का है? डालो. Help. अरे get your hands ready man. चलो, दोनों लोग मिलके डालो.
So you see that we have tried to do something in our hospital, which is a very new method. So thank you all very much. Jai Hind, all of you. Apologies to Dr. Purvi. I have taken about 5 minutes more than my time. Thank you.
Thank you very much, Dr. Ajay. No issues. It was good presentation. Actually, I wanted to take 2 more minutes. Any other striking points? I think the one point we should highlight is many times we see that AC and fan. People only think cooling is AC and fan, but we are.
Ma'am, your voice is quality. Ma'am, kindly repeat, please. I am unable to make out. Yeah, please.
Little better now?
Yeah. Better now. Please go ahead.
Yeah, just wanted to highlight few points and ask a follow-up question that many times people think that cooling is only limited to ACs and fan, but we are saying that cooling of actually body cooling is much more than that. It's active cooling, rapid cooling by either cold water, ice, and if in the periphery there are not other, at least you have taco method or some water, cold water can be used, right?
See, as I discussed in my talk also, the maximum rate of cooling through full blast AC, you put 2, 3, 4 ACs in one room, fanning, everything, evaporative cooling maximum rate is 0.03 centigrade per minute, which is 1/5 of what is required. The required recommended rate is 0.15 degree. And water immersion takes it even beyond that, 0.2 degrees. So in order to save lives, first and the foremost, if you ask me, early initiation of cooling, जो भी है हाथ में, don't wait for an ideal condition to immerse in a tank. जो शुरू है वो शुरू कर दो. Then if you have access to immersion cooling, definitely it is better than evaporative cooling. But early initiation and using the best method remain the mainstay of treatment. Seizures, treatment cooling. Hypotension, cooling. Tachyarrhythmias, cooling.
Okay.
Besides, obviously, other methods also, but the mainstay of treatment of a heat stroke patient should not be कि हम लोग बस IV fluids से, you will have a very high mortality. Thank you.
Okay. Okay. Thank you very much. If anyone has a question, they can type it on the chat box. Meanwhile, I had one question for Dr. Naresh. If he's here, somebody was asking about is there sub-district or mandal level mapping of heat wave by IMD? Is Dr. Naresh here? Are you here?
Just will you repeat, please?
Sir, someone wants to know whether there is a sub-district or mandal level mapping of heat wave by IMD.
No, presently we are issuing for the district level as well as city.
Okay.
Okay, in city forecast we issues.
Okay. Okay. Thank you, sir. Okay. So I don't see any questions, any further questions for Dr. Ajay or Dr. Naresh. So in that case, I will move forward with the next presentation. So as you understand, adult clinical management of adult is important, and as well as pediatric patients also need to have special attention in terms of heat-related illnesses. So we have our next presenter, Colonel Dr. Subhash Chandra Shaw. He is a professor in pediatrics at Army Hospital, Research and Referral, Delhi, with 25 years of service in Indian Army. He is also a neonatologist and works extensively for care of extreme premature babies. He has 82 publications to his credit and is actively involved in advocacy and training of HRI in children. And he has also helped us draft guidelines for children regarding emergency cooling. So I will invite Dr. Shaw to take next session. Sir, yes, sir, you can go ahead. I think you are on.
अभी 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 हुआ sorry can you hear me now? Am I audible?
Yes, sir, you are audible.
Okay, so should I start, ma'am?
Yes, sir, go ahead.
Is my slides visible now?
Yes, they are visible in a normal mode.
Okay, okay. Let me just make it slideshow. Yeah. Now it is visible?
Yes.
Okay. I'm sorry for the technical glitch, and my job is a little simpler because my previous speaker has already spoken a lot about the management part. But still, there are some nuances in pediatrics or in children, so I'll dwell upon them and also talk about preventive part a little bit more. So, as the heat-related illnesses in children, so I'll be covering basically under three heads. One is preparedness in schools, where the children will be going during daytime. So it is important that school authorities are aware about the problems and prevention of it. Then awareness in parents and children, they themselves have to know the problems and to prevent the complications or anticipated issues regarding health related heat related problems and management of heat related illnesses as such. So in preparedness at school, the most important thing is potable water. So whether it is a village setup or town, city, I mean, there has to be availability and accessibility to potable water. This is a must. Water coolers need to be clean because this is the time when often the coolers may not have been cleaned for long, and there has to be ensured that regular cleaning and monitoring is being done. Classroom should be well ventilated, goes without saying that, ventilation is must, cross ventilation rather, and there should be enough ceiling fans or AC as the case may be. There should be backup electricity to be ensured during class hours because it may so happen that, during peak summer, the electricity is gone. So there has to be backup electricity. And avoid plastic water bottles. Then school timings, it should start early and close before the peak temperature. Generally, the peak temperature between 12 to 3, and the school authorities should be mindful that you start early and you close also early. Flexibility of games and sports period based on temperature and humidity factor. And as we know that humidity factor is a very important factor, like in coastal areas, the temperature even 37 degrees is very high, and in plains it is 40. So humidity adds on to the problem. So this also needs to be seen. No major outdoor sports events should happen during the summer months, and that too during the daytime, that is between 12 to 3, that should be avoided. And if at all, the events can take place in indoors and not outdoors. There's some problem in the slides. It's not moving. Yeah. Clothing should be comfortable, loose, lightweight, and light colored. And as far as possible, neckties should be avoided. And as I said, strict adherence to summer holidays and flexibility to prepone or postpone if the need be. I mean, if the temperature changes suddenly or there is suddenly heat waves coming up, then there should be flexibility in the hand of the administration to change the summer holidays. Now, what about children, like going for sports activity? Anything special in that? I think it was also mentioned by the previous speaker that once somebody is coming from a cooler climate to hotter climate, there should be acclimatization because they are at higher risk. So maybe when they if the children have come from a cooler climate, so they should not move out in the open for about a week and then acclimatize gradually in warm weather and increase their activity over next 1 or 2 weeks. They should remain well hydrated before, during, and after physical exertion. Very, very important. Then there should be some mechanism to screen for any health condition or medications that may predispose to heat-related illnesses, and particularly watch for fever or gastrointestinal illnesses. Why so? Because once fever is there, that child is even more prone for dehydration or heat-related problems. And also gastrointestinal illnesses, like if somebody is having diarrhea, is also again at more risk of going into dehydration. Similarly, drugs like beta blockers and Lasix and this kind of medicines or cardiac medicines, your sympathomimetics, anticholinergics, so all of them will be putting child at risk of more dehydration or heat-related problems. Children should wear light colored garments, and as I said, and that should be lightweight, loose fitting, and then even it should be seen that the uniforms and practice gear should be made from open weave or sweat wicking materials to facilitate evaporative heat loss. And when the weather is extremely hot, then practices should be scheduled for mornings and evenings only, when the temperature is generally cooler. So if one figure one needs to remember, probably 12 to 3 is the time when there should not be sports activities during this time. Now, what should the students should know? So they should be encouraged to drink water by teaching the beneficial effects of drinking water, And also water with added minerals, as heavy sweating will remove the salt from the body that need to be replaced. Now, children should know that you should not drink only when you are thirsty. You should drink beforehand. That is the catch. I mean, they should be taught in such a way that you have to be well hydrated during summer. So please drink water even if you are not feeling very thirsty. Avoid fruit juices, sugary drinks, or carbonated drinks as substitute of water, because these days people feel that carbonated drinks are okay. They are also liquids and they have some water. No, I mean, they should be avoided. And our Indian traditional shikanji or Indian lemonade, aam panna, bel sarbat, these are okay. Then teach children importance of bathing each day to prevent skin infections, because these also are very common now during summer. And never leave children in a parked car, even if the windows are open. And if possible, wear sunscreens, broad spectrum ones, and also use umbrella or hat once outside shades more than normally done. Now, they should be also be aware of early signs of dehydration. The children should know, the teachers should know, the parents should know. Now, what are these? These are like feeling faint, extreme tiredness, more than usual tiredness, intense thirst, fever, because fever can be a sign of infection also, bacterial, viral, whatever, or even hyperpyrexia because of hyperthermia or because of heat also. Headache, nausea, vomiting, not passing urine for hours or passing concentrated urine. I'll show you a good diagram how to know that, the more the urine is concentrated, the more the child is dehydrated. Breathing faster or deeper than normal, skin numbness, muscle cramps, dry tongue, or sunken eyes. So any of them you see, even the students or the children, if they feel or the teachers see, they are all early signs of dehydration. This is what I was telling, that urine color also says a lot. Now, if you look at the urine color, this is taken from Australia government website, like the first 1 and 2, like they're clear urine. Okay, so the child is hydrated. And if the urine color is between 3 to 4, that means it's mildly dehydrated. So drink a glass of water now. So that should be the message. If the color is between 5 or 6, that means, it's an indication that you are really dehydrated. So drink 2 to 3 glasses of water now. And if the color of urine is between 7 and 8, that means you're very dehydrated. Drink a large bottle of water. So this kind of pictures can be pasted on the bathrooms or places where they go for urination. And the students also can see, okay, my urine color is like this, so probably I should drink more water. So very easy method, but very effective. So now I come to the heat-related illnesses in pediatric age group, and there can be many already, mentioned by my previous speaker, and they can be right from, benign ones like heat rash, excessive irritability and dehydration, heat edema, then heat cramps, heat syncope, heat tetany, heat exhaustion, and the worst of all is heat stroke. So now, just knowing about the conditions is not good enough. We should be able to pinpoint that it is because of this. So like if it is heat rash or prickly heat or miliaria, so cardinal features will be itchy rash with small red bumps. And it is seen in the setting of heat exposure, of course. And the color will be like diffuse red color, and skin or vesicular rash will be there. There will be the cardinal signs. So what will be the negative findings? Like it will not be focally distributed. Like if it is focally distributed, then it is contact dermatitis. A very simple clinical message. Now coming to heat cramps. So painful spasms of large and frequently used muscle groups, that is what is heat cramps, and the child will be uncomfortable, and there will be difficulty in fully extending affected limbs or joints. But you should make sure that there is no contaminated wounds or tetanus exposure or no seizure activity, because these are the closed DTs. Then come to heat exhaustion. If the child is feeling overheated, lightheaded, exhausted, weak, steady, feeling of vomiting, child is sweaty and thirsty, unable to continue activities, it is heat exhaustion. How will the child look like? They will be sweaty, plus skin, hot skin, normal core temperature maybe, but then the child will be dazed, there will be generalized weakness and slight disorientation. Slight disorientation, not great CNS features. What you should ensure that there is no coincidental signs and symptoms of infection, because as I said, infection will also cause fever or high temperature. no focal weakness, no difficulty in swallowing food or speech, and no drug or overdose history. Coming to heat syncope, that is feeling of hot and weak, lightheadedness followed by a brief loss of consciousness. It will be brief, generalized loss of consciousness in a hot setting and short period if disorientation, if at all it is there. But what you need to ensure that there is no seizure activity, there is no loss of bowel or bladder continence, because that will indicate towards seizures. No focal weakness or no difficulty in swallowing of speech. Now, heat stroke is the worst one, and it is severe overheating where the temperature will go beyond 104 Fahrenheit or 40 degrees centigrade. There will be profound weakness and there will be disorientation. CNS features will be marked here. The child will not be alert. There will be other. The child will be flushed. It will be dry skin. Core temperature will be more than 40 or more than 104. There will be altered mental status with disorientation. The child may be in coma, convulsions. The child will have tachycardia, may or may not have hypotension. So here also you need to rule out co-associated or alternate cause of this, that is some signs and symptoms of infection, any focal weakness, and any drug or overdose history or any difficulty in swallowing or speech. So this is some very simple clinical clues to diagnose these clinical entities and also what you need to ensure the negative history. Now I come to the simple management part and the prevention part. So for prickly heat or heat rash, the treatment is place the child in a cool environment, remove any excess clothing, and avoid application of lotions as far as possible. Prevention is using of loose fitting clothing or removing excess cloth, avoid direct sunlight, avoid excessive heat. And if the child is, a small one, a breastfed one, then frequent breastfeeding. If it is in the breastfeeding age group, that is in 6 months, 1 to 6 months. Next is excessive irritability and dehydration. Again, what you should do is placing in a cool environment, remove excess of fluids. Heat edema, which is more common in adults, by the way, where swelling of feet or ankles will take place because of local vasodilatation there. The treatment again is removed from the hot environment, placed in a cool environment, and elevate the affected extremity. That should suffice generally. No drugs are required. Heat cramps, it's common in young athletes. It's a painful one, involuntary spontaneous contraction of muscle groups of legs, calf, groin, and there's difficulty in extending that part. The treatment again is removed from hot environment and rehydrate. Frequent oral fluid should be given. If persists, then IV fluid also may be required, and addition of salt in water will also help in this condition. Coming to heat syncope, it is seen with prolonged standing in hot environments that causes vasodilatation and so fall in blood pressure due to venous pooling in the legs. And this will cause decrease in venous return to the heart, causing a fall in cardiac output, and all of them will result in fainting or feeling lightheaded. What you should do, remove the child immediately from the hot environment. Oral dehydration solution with salt containing fluids, as I said, like ORS, lassi, nimbu pani, lime water with salt and sugar, rice water, dal water, even coconut water, sattu, in anything, but some salt has to be there. So this helps. In heat tetany, it is differentiated from heat cramps by the fact that there is very little pain or cramps in the muscle, but that picture was also shown of tetany by the previous speaker. Again, you remove the child from a hot environment, calm the child to decrease hyperventilation, because hyperventilation is causing this problem, and intravenous calcium also will help once the child is admitted. Now coming to heat exhaustion, as I said, after prolonged heat exposure, the body temperature will rise up to 104, not go beyond 104, and it will lead to dehydration, tachycardia, vomiting, fatigue, and headache with normal mental status. The treatment would be again removing the child from the hot environment, oral rehydration with salt containing fluid, look for any dyselectrolytemia, intensive care monitoring and IV hydration is required in these cases, and rule out sepsis. Last, coming to heat stroke. Now, we should give little more attention to this because this is what is likely to kill the child or cause mortality. In this, the most important feature is there will be altered mental status in heat stroke. There will be disorientation, delirium, seizures, obtundation with elevated core body temperature going more than 40 degrees centigrade or more than 104 Fahrenheit. and without any prior signs of stroke, history of infection, or signs of medication overdose. Or there can be alternate mental status with hot and dry skin. Remember, it is not sweaty skin, it is dry skin now, and deranged vitals, tachycardia, tachypnea, white pulse pressure. And it should happen during the heat wave season, that is between March to July. This is more common. So in heat stroke also, what needs to be done? This is a case where the child has to be admitted and will require intensive care monitoring. So admit the child, check airway, breathing, circulation, give oxygen, give IV fluids, do these tests, random blood sugar, as was told by previous speaker also. Hypoglycemia is common in this condition. Arterial blood gas, there may be lactic acidosis, there may be metabolic acidosis, electrolytes may be deranged. Liver function test, your OTPT might rise, can go more than 1000. Renal function test, urea creatinine will be deranged. Coagulation profile will be deranged, may be deranged, and neuroimaging to rule out any CNS bleed, etc. Now, if still we have a doubt about between heat exhaustion and heat stroke, this should clarify it, that in heat exhaustion, there will be increased thirst, weakness, extreme tiredness, fainting, muscle cramps, nausea, vomiting, irritability, headache, increased sweating, but there will be cool, clammy skin. There will be sweating, and body temperature will not rise beyond 104 or 105. On the other hand, heat stroke will have severe headache. The neurological features will be very prominent, will be confused, fast breathing, rapid heartbeat, hard to wake up or can't wake up, seizures may be there. Here it will be dry skin, flushed, hot and dry skin, and body temperature will go beyond 105. Why this distinction is important? Because heat stroke is something where immediate and intensive care management is required. Now, what are the danger signs? Like we read about danger signs in IMNCI also for children. So the danger signs are refusal to feed, excessive irritability, decreased urine output, dry oral mucosa and absence of tear or sunken eyes, lethargy, altered sensorium, seizures, bleeding from any side. All of them are danger signs. So this should be known to us. Now, coming to the management of the other problems like heat edema, prickly heat, cramps, and tetany. So mostly it has been mentioned, but just few more things if it has not been mentioned so far is that for heat edema, as I said, elevate the leg. It usually resolves spontaneously in few weeks. Compressive stocking can help, and diuretics are not effective. That is very important. In prickly heat, you can use antihistamine and wear clean, light, and loose-fitting clothes. Avoid sweat-generating situations. Chlorhexidine in a light cream or lotion base is okay. Calamine lotion is also okay. In heat cramps, fluid and salt replacement, IV or oral, and resting in a shaded, relaxed environment. And heat tetany, calm the patient to reduce respiratory rate because that hyperventilation is causing respiratory alkalosis, and so tetany will be more aggravated. And remove from hot environment. Calcium will also help in this case. In heat syncope, as I said, rule out other causes of syncope, and IV drip may be required in this. And heat exhaustion, remove the patient from that hot area. Volume replacement is necessary. Put an IV line, give IV fluids. Aggressively cool the patient to core temperature 39. As was told by the previous speaker also, that you should have a target of around 101, 102. And then stop, because if you keep on going, otherwise hypothermia may occur. And in heat stroke also same thing, but here it is much more severe in nature, and so there will be requirement of intensive care monitoring, and also a lot of investigations might have to send because multiple organs may be getting damaged or multiple organs may be affected in heat stroke. Now, what about hospital preparedness for heat season? I'm not too sure if it has been discussed. So this is a basic minimum should be there in any hospital, irrespective of where the hospital. You should have dedicated bed for these heat-related illness patients. In a cooler area of hospital, everything is important. You should have thermometer, ORS packets, ice packs, BP apparatus, silver sulfadizine cream, calamine lotion, chlorhexidine, cold IV normal saline, dextrose 50% in water solution, glucometer, testing strips, ECG equipment like ECG machine, gel, electrodes, ECG paper. You should have cooling equipment, AC, cooler, fan as per requirement. Water cooler should be there. In medicines, as was told by the previous speaker also, that the best drugs are lorazepam and diazepam. It will help in seizures also and also in shivering also, because there may be severe shivering when the patient is getting cold. And you should have ambulance facility with ice packs and cold water. Now, regarding prevention of heat-related illnesses, as I said, always prevention is the best policy. Prevention is better than cure. So always look out for the weather warnings issued by Indian Meteorological Department. Teach kids to always drink plenty of liquids, water and salt water, or all those Indian ampanna, nimu pani and all those before and during any physical activity in hot sunny weather, even if they are not thirsty. This is very important to tell them. Make sure kids wear light colored loose clothing. Remind kids to look for shaded area and rest often, because they would like to play outside. So they should be told that, okay, intermittently you come to shaded area and rest for some time. Avoid activities during peak summer, as I said, between 12 to 3 p.m. Don't let kids participate in heavy activity outdoors during the hottest hours of the day. And teach kids to come indoors immediately whenever they feel overheated. So continuous, education of them and, role modeling, telling them, ensuring that they have water with them. All those things are important. And very important, never leave a child alone, not accompanied inside a parked closed vehicle, because inside vehicle, it will be very, very hot. First aid, like before reaching the hospital, what the school can do or in community, it can be done. First and foremost, bring the child indoor first or into the shade first immediately from that hot area or from that overheated area. Remove the clothing of the child while maintaining the dignity. Have the child lie down, raise the feet slightly, because that will help in if there is hypotension developing or if some cardiovascular compromise happening. Increase airflow to child using fan. Spray normal tap water or tepid sponging. Just remove the clothing as much as possible and then just spray normal tap water and put a fan over it. That's it. If the child is alert and awake, then only give frequent sips of cool, clear fluids, because that also should go simultaneously. But if the child is vomiting or the child is not alert, awake, then it is not correct to give any fluid. Just, in fact, turn to their side to prevent choking. And as I said, if the child is unconscious, don't give them anything to drink or eat. Now, this algorithm is the last slide where what we should do in healthcare facility. So again, ABC, airway, breathing, circulation, quick assessment of neurological impairment, quickly get an IV line, send relevant investigation, as I've already said. If there is features of shock like tachycardia, hypotension, or CFT, keep giving normal saline boluses. Each one is given 20 ml per kg per dose over 10 to 20 minutes, and you can repeat it maximum up to 60 ml per kg, but be sure that there is no fluid overload. And then, of course, issued active cooling measures, like, as I said, remove all clothing, keeping patient's dignity in mind, cover with a thin wet sheet and spray cool water. Ice packs can be used over head, neck, groin, and axillary regions. Use mist fan, evaporative method, tepid sponging, cool blankets if available. Make the child lie down, raise the feet slightly. Very important. Avoid paracetamol and NSAIDs. It has got no role in this condition. Rather, it will create problem for us. Consider gastric lavage with cold saline, that is permissible. Then these patients or the children should be closely monitored. Temperature should be taken every 15 to 30 degrees and never overcorrect to 38 or below. Stop at 39. Even hypothermia can be fatal. Vital signs should be seen. Cardiac rhythm, ECG, mental status should be frequently monitored. Look out for two things. One is hypothermia, that you can ensure once you should stop cooling once the temperature has reached 39. And while giving fluids, remember that acute pulmonary edema can also occur. So be on guard and don't give unnecessary fluid also. Then, as I said, for seizures, midazolam or lorazepam are the best one, and you should give that much only. And for shivering prevention, again, the same one can be used, midazolam or lorazepam, or if the child is already intubated, then paralytic agent. Look for signs of coagulopathy. You should do ABG to look for metabolic acidosis. CT brain is done to look for complications or to rule out any other intracranial pathology. And you continue management and refer to intensive care unit if your hospital doesn't have a proper intensive care unit. And of course, inform the parents and other people who have brought the child about the patient's condition and prognosis. Ma'am, I've finished here. I would like to take any questions regarding heat-related illnesses in children. I finished.
Thank you very much, Dr. Shaw, for that very informative session on pediatric HRI management. I had one question that, like earlier we saw in adult patients, it is very important to have immersive cooling, but I think in children it is different. So what is the best cooling method for children?
Yeah, so children, as I said, the first thing is bring from outdoor to indoor. I mean, that situation first avoid that overheated place. You first bring the child inside in a shaded place, and then, as I said, remove clothes as much as possible, and then just sprinkle water. Water, even normal water will also do. If you have, ice and all, bring them, put on the groin, axilla, and all those, or just put water and just put a fan over it. So just by evaporation also, the child will be cooled. So this much of basic thing can be done everywhere, I feel. And as was told by the previous speaker also, it is how rapidly you are doing, how fast you are doing, and rather than waiting for vehicle to come to hospital, this much one can do there itself. Anywhere it can be done rather. So that I would say is the best policy for children.
Yes. So for both adult and children, on-site cooling, wherever the patient is found,
Yes, on
actually
site.
cooling them on-site is most important. I think in that case, ambulance preparedness and also sometimes teaching, first responders may be useful for finding and early treating by cooling in the field. There is one question, and it can be for both of you, Dr. Ajay and Dr. Shaw. Can we give ORS prophylactically to prevent HRI? And how many ORS sachet we can give to worker per day who is working in hot environment?
See, I showed a slide in between my management of heat exhaustion, heat stroke. So if they not only ORS in itself is not be all and end all, but it is a very important adjunct. So if a person is working at 90-degree, I wish I could project that slide. Just can I share my slide once again?
Yes.
Just hold on,
Sure.
I will show. Just so not only ORS alone, but now is it visible? Na? I'll
Yes.
just show that particular slide. In fact, for the paucity of time, I just yeah,
it's okay.
this one.
Yeah.
Yeah, this is it. See, so have a look at this one. Okay. So if there is increase 90-degree, then take rest every 45 minutes. Or take at least 45 minutes of break every hour. Okay. And then what do you do in this break? You take ORS, you rest in a cool place. So there is, but we should not, we should not think ORS as a solution to each and everything. Take ORS and work like hell. It should not be recommended. But it is a very, very important adjunct insofar as prevention of heat stroke is concerned. But it's just another method, one amongst the many, not all in all. In fact, in some Gulf country, Middle Eastern countries, they have 3 flags: red, yellow, and green flag. Green is you can work, and they have a wet bulb globe temperature measuring equipment right there. So they measure it, and if there is above 90-degree, then every 1 hour, every 45 minutes they raise this red flag. So the person takes some break. If it is between this degree to that degree, they raise flag every some amount of time. You're getting my point. So what is emphasized is ORS is an important adjunct, but you should not place too much of emphasis कि भाई ORS पियो और काम किए जाओ. ऐसा नहीं होगा. ORS is one amongst a lot of steps which are important. Thank you.
Okay. Thank you very much, sir. Dr. Shaw, do you want to add anything in case of children?
Yeah, ma'am, am I audible?
Yes, sir.
Yeah, so I'll also say the same thing what sir said, in the sense that it's not the ultimate solution. I mean, better to use ORS as a treatment rather than prevention, I would say. Firstly. Secondly, the other homemade things also are equally good. I mean, Nimbu Pani and Ampana and those kind of things. More importantly, when there are features of like heat cramps or tetany or heat exhaustion and all, there probably comes the role of ORS more as a prevention. I mean, it is not that important, but if there is situation is so that it is heat waves are going on and you're not feeling good, there's a chance that the child will be playing in outdoor and you can't help it. So maybe you can take ORS in that case, but there's no hard and fast preventive role of ORS as such. But yes, in case of heat cramps, heat exhaustion, syncope, those kind of situations, it will help because it has got salt.
Okay. Okay. Thank you very much. And there was one question about shivering. What to do with shivering when cooling?
Question for me?
For Dr. Ajay and also for you. Please go ahead. So how do you manage in children and adults shivering
Okay.
while cooling? Yeah.
So as I said, some amount of shivering will take place when cooling is going on. If it is unbearable, if it is too much, then those lorazepam midazolam can be used. Just a single dose intermittently can be used. But some amount of shivering will take place. It's not that bothering. But yes, if it is uncontrollable, one can use it. But I mean, why to use unnecessary drugs? That kind of thing. Doctor Ajay.
Okay.
I agree with Dr. Shaw's statement absolutely. So shivering, some amount happens, but ideally we should not be much bothered about it. We can, if there is very less indication of drugs to control shivering. So we should not be too much worried. What we should be worried about is the core body temperature.
Okay. Okay. Thank you very much to both of you for highlighting clinical aspects of HRI management. I have put some links as a PDF for people who are interested of various guidelines which are available online on website and YouTube for NPCCH, where you find recorded lectures. And separately, I have also put Google Drive link where all the materials are also there in a drive. So you can use that for further training. So before I move to surveillance, and I will just move through very few slides. I would like to mention that because we mentioned about mass gathering, so there are guidelines on managing mass gathering and what kind of health sector preparedness is required. So whenever it is there, you can utilize the guidelines, which is part of emergency cooling, and also advisory that we will be issuing. So that is one thing I wanted to mention. And I will quickly go through surveillance because once we identify the disease, reporting of it is also important. In NPCCH, we have this heat-related illness surveillance, and we are collecting data from all the facilities, PHC and above. So just I will quickly go through it. I had taken separate lecture on this last month, and it was extensively taken. So I'm just moving through right now. So this year we have moved to patient level data collection. The purpose of the surveillance is the foremost assess burden of illness and mortality due to heat in population to get near real-time understanding for response planning. And if we have good quality data, we can utilize for various action plans at state, district or sub-district level, and also understand impact of climate action and changing climate in the long run. Right now, we are just limited to near real-time understanding of cases and deaths. This is the guideline. These are published in 2021, which is the base of the surveillance format and also health facility preparedness and clinical management. And I have shared the link with you in the chat box and also page of the link. So what are we capturing? Direct health impact, which is suspected stroke case, suspected stroke death, and confirmed stroke death. And indirect health impact will be emergency attendance and total deaths in the facility. And there are subcategories in this. So we are trying to capture whether the emergency attendance or total death change with the temperature, whether they are increasing, decreasing. So what we are capturing here is medical emergency, pediatric emergency, casualty. And in death, we have three categories: cardiovascular death, suspected stroke death, and all other deaths, including unknown or broad death patients. So if we understand how it is captured, so these are a subset of each other. So first of all, it will be suspected stroke case when it enters health facility. And if that person dies, then it is a suspected stroke death. And if the death is confirmed by various measures that I will inform later, then it is a confirmed stroke death. But the position here is that they are a subset of each other. They are not independently reported, and that is how they are also counted in the surveillance system. So when you enter some case, it will be case that will be again a subset of death, not a separate death. And sometimes when the patient is brought dead and not entered facilities as a case, then it is directly entered to the suspected heat stroke death. So it is visual presentation is like that. This is the largest chunk of patients, a suspected heat stroke case, and some of them will be death, and then part of them will be confirmed as a death. And in broad dead cases, they directly go to suspected heat stroke death. So we are capturing all this data so that we get daily understanding. That is why we have this more of a syndromic sort of definition of suspected heat stroke case that we are capturing. It includes altered mental status, elevated core body temperature, or altered vitals without sign of stroke, history of infection, and medical overdose. Confirmation of heat stroke is not required for reporting in surveillance. However, it should be done for medical management. As far as reporting is concerned, that is why we are capturing suspected heat stroke case, because it is informed right away and it need not to be waited for confirmation, because then it is a different time and the exposure for that particular day changes if we wait for confirmation. So the suspected heat stroke death is following the case if it is in hospital, and if it is broad dead, then it has to be identified. We have a checklist for that you can utilize in clinical setting and circulate among your medical professionals to help them identify whether it is a suspected heat stroke death or confirmed heat stroke death. And I will show you. Now, confirmed heat stroke death as a health facility and health sector, we are encouraging you to have clinical case sheet or clinical confirmation of death rather than doing post-mortem every time. So it is not necessary to have post-mortem. Clinical confirmation of death, confirmation of heat stroke death is acceptable. And again, you can use the checklist that I will be showing you. Post-mortem, it is available, it is fine. Verbal autopsy or death investigation, if it is done by using the form that NPCCH has, that is also fine. And if the state has 3-member committee, then it is also acceptable to have that sort of confirmation of death. However, I would emphasize that in the health sector, we will be okay with accepting clinical confirmation of death. And cardiovascular death is obviously myocardial infarction, heart failure, cardiovascular procedures, hemorrhage, or other cardiovascular causes that are clinically confirmed as cardiovascular death. So this is the form that I was mentioning. It provides the criteria to label heat-related or heat stroke death in confirmed or suspected situation. This was developed last year with the committee of clinicians during the summer. It is different scenario whether the temperature was measured before death and it was elevated. There was mental status change. So you can go through see the scenarios, different scenarios, and it that can help you label that particular death. We have also kept broad death situations where if antemortem core body temperature is not available, but you have mental status change, their environmental criteria is met, and there is no other definite diagnosis, then it can be suspected heat stroke death. Then other clinical assessment. If the clinical assessment is not possible, patient brought dead, then what are the other information you have, like chronic conditions was there or not, environmental criteria met or not. So these are the things that we have. And finally, if patient is brought dead and there is no other information, only if you have information about their occupation or last work conditions, that can also be used. And following is the environmental criteria. So this is the checklist that is available and circulated to the states last year. I think they can also recirculate it again to facilities. This is the guideline for autopsy findings. There are challenges in terms of heat stroke death. If the exposure is very less, then most of the organ changes will not appear in autopsy, and autopsy will be also inconclusive. So these are the guidance documents that are issued by Ministry of Health and that can be utilized to see how a death probably related to heat can be labeled or certified or identified. This is a guideline for verbal autopsy, and it is part of this national document that can be utilized in case no other confirmation method is available to you. And this is filled by epidemiologist or medical officer as a circumstantial evidence for that. So I will go to IHIP platform and show you quickly. For the people who don't know, the surveillance is on IHIP platform of ministry. And NPCCH is the web page that you have to go through. It is a daily reporting of cases and deaths. If you are reporting today, you are reporting for cases and deaths happened in your facility between yesterday 8 a.m. to today 8 a.m. It is a year-round surveillance, and PSC and above, all facilities are required to report. Reporting is mandatory, and state and district can observe monitor the reporting and utilize the data for further preparedness or response. As I said, this year we have changed the surveillance reporting to a patient level data collection from aggregate, and there are 3 sections of this form, the updated form. The first section talks about aggregate data. Second section is about patient demographics, and third section is about clinical information of the patient. So I will just go to the live website and just show it. I think it will be easier to see and just quickly get it. Okay, is it visible? Hello. Yes. Okay, so I hope it is visible. Can anybody confirm this is visible? Am I audible? Yes, okay. Thank you. So this is the aggregate part of the, yes, sir, thank you. This is the aggregate part of the form. So emergency medicine, pediatric and casualty patients that needs to be entered every day. So a facility has to decide which unit is there in the facility and report for that unit consistently. So many big facilities have separate emergency medicine and pediatrics. Small facilities might just have casualty division. They decide to report that and consistently report that thing. In deaths, total facilities in the deaths are required to be reported as aggregate format. The gray out part are usually the totals of auto totals from the line list or from the aggregate. So gray fields are not allowed to be entered. And now it comes to patient level data recording. So this is the form. You have to open add new patient record. And in demographics, the demographics section is almost like the IDSP's demographic details that needs to be entered. Name, age, gender, location, present address of the patient. 3 questions we have added here is a socio-economic card. So there are a few options in the socio-economic cards that needs to be selected, like BPL, Antyodaya, Annapurna, and other. What was the last occupation of the patient? So we have tried to predetermine the occupation categories like construction worker, postman, emergency responder, guards, professional athlete, a farmer, homeless, some others. And then just before the onset of symptoms, what person was doing. So that gives us information about the exposure, potential exposure, whether it is outdoor, indoor, or whether it is exertional or non-exertional. So the categories are outdoor in sitting, traveling, closed vehicle, non-exertional, outdoors in working, exerting, playing, then near heat source like fire, furnace, hot engines, or machines, indoors at work, school, office, home, and in mass gathering or tourist places where there is additional exposure to heat with many people alongside. So that is the information social demographic. Now we come to clinical. It is important. In clinical, we are accepting only 2 diagnoses: suspected heat stroke and cardiovascular. All the things that are collected mainly are suspected heat stroke. So once you select it, that is automatically a case. You enter the information about the symptom onset, OPD, IPD, date of emergency visit, and then status at the date of reporting. So you are going to report this patient tomorrow because it has arrived today in the facility. If it is admitted, you select admitted. Other options are died, referred, or recovered. So you select best outcome, whatever it is, for the next day. So you are going to report to tomorrow this patient because it has happened between 8 a.m. to 8 a.m. period. and then if it is improved after cooling, and other comorbidities. So these are the questions. And once you submit it, it will be saved as an admitted patient. So you can see here, it will show like this, admitted, and then there will be a red section for final outcome. So in the portal, you are expected to come back to enter the final outcome. I will not be able to show it right now because I have not entered all the data and not saved the patient. But once you admit it, you can come back whenever the status changes. So if it is recovered, referred, or died, the another 2.8 is the field that will open. You can just select the final outcome whenever that happens and put the date of the final outcome. So that's how a suspected heat stroke case is saved. Suppose there is a death, the person just died directly, you can enter as a dead, or you can come back after admission and you can convert it to death. In death, you have some of the similar questions, but you have specific questions about whether it is confirmed or not, and was the deceased found unconscious or dead, yes or no. This is to identify whether patient has died outside of facility, and especially broad death situations, this can be used. So if we know with the person died in home, workplace, social gathering, on road, all these things can be selected. Finally, you can select date and time of death, and how it is confirmed. Because if it is confirmed here as yes, we would request you to enter, upload clinical case sheet or postmortem report, whichever is there, that help you confirm. So these are the provisions to upload the form. It will open once you have properly entered the data. I'm not doing it right now. You save it and it will be saved as death. So this is how we have expected, and the case and death and subsequent confirmation will be proportion of the previous group. And last one is cardiovascular. So cardiovascular, we are only collecting death. So it will be directly died, and you may inform about the death, OPD, IPD visit, and death. So it will be similar to that. So this is the form, and it will create a line list. Once you have a line list, it will reflect as a number here on that particular facility for that particular day. So this is in short is form. There is another lecture online that you can see for more information. So I will move to any questions. When will the recording of this session will be available within 1 or 2 days. I think this live will be recorded, but we have the full recordings also, so we'll upload. Any more questions? Okay. I hope you all get the resource link and other links. So I think I will end the session, and we look forward to further trainings down the line. And tomorrow is also a similar session. So if somebody has missed today, they can join us again tomorrow through WebEx or through YouTube. So you can inform them. With that, I think I will end the session. Thank you very much. Have a good day.